Okay, Daniel, I think we're good to go ahead and get started. We may still have some join us, but that is totally okay.
Okay, happy to. All right. Well, welcome everyone. This is the fourth session, so you kind of know the drill by now, but my name is Danielle Bagnell. I'm excited to be here with you. I don't have any financial relationships with any of this. So you guys will be getting a CME credit for your time today. And reminder, there is a survey at the end, and there will be a QR code for that you can take that survey, and then that'll help with getting that CME credit and all those things. Also, we have our disclaimer as usual. So this is a custom education training made for you guys. That's what it's intended for. We do give, you guys do have access to the materials and whatnot, and nothing is ever intended to replace your independent professional judgment. I'm just letting you know what, your the downstream effects of your words so that you can make informed decisions when you are writing your diagnostic statements and such, and just kind of helping bring that information to you. So today we are going over our cerebrovascular diseases, dementia, specifically severe persistent asthma, and then your chronic obstructive pulmonary disease. So starting with cerebrovascular diseases. Cerebrovascular diseases refer to conditions that affect blood flow to the brain. So that can be stroke, your TIAs, aneurysms, vascular malformations. It's typically caused by narrowed, blocked, or weakened blood vessels, which can lead to brain damage due to reduced oxygen supply. So we have things like intracranial hemorrhage, and those will go to HCC's 248, and then you have your ischemic or unspecified stroke, and that's a different HCC. So giving that detail will make a difference. We also have your hemiplasia and monoplasia, and we're going to talk about that in addition to this because they're the most common residual effects of this, and so I'll make sure that we understand how those come into play as well. So I know every EMR is a little bit different, but I assume you can see the code when you are going in there and selecting things. So just a heads up, your codes that are in the I-60 through I-67, those are supposed to represent an acute, it's happening now, that sort of situation. So those are things that we'll see in the hospital, for example. That's where those kind of things usually get diagnosed and treated. When they are in a clinic at a later time, it's either a history of and there's no residual effects, or there's a residual effect and that is the thing that you're trying to capture. And that code will start with an I69. And that's how you know that you're in the right ballpark when you're trying to type in key terms, and it pulls up these, helpful list of codes just to kind of, give you the heads up there that that beginning part can really let you know. So these late effects include things like neurological deficits that persist after the initial onset of a condition that's not acute, I-60 through I-67 range. And those neurological deficits are caused by this cerebrovascular disease. They may be present from the onset of the acute, or they may arise anytime after. Our coding guidelines tell us there's no time limit for sequela, so that's something that if you tell me it's due to that, then great, I will, code it as such. So codes from the category I69, sequela of cerebrovascular disease, they specify, there are ones that will specify the hemiplasia, hemiparesis, and monoplasia, and they need to know whether it's their dominant or non-dominant. And so we do have defaults for if it's not in the documentation. The book will tell us to go ahead and assume everyone's a right-handed person and that their left side is non-dominant and their right side is dominant, unless of course you say they're ambidextrous, then either side you say is weak, we'll use the dominant for. So if you are, seeing a patient that having whether or not the side that's weak is dominant is an important detail. And especially if they're a left-handed person, you don't want us defaulting to that being their non-dominant when it truly is their dominant side. So just a heads up that happens if it's left unspecified in the documentation. So codes from category I69 can be assigned to the record if there's a current cerebrovascular Okay, so let's start over. If you have the acute code and the residual from code, it may seem like an error, and sometimes there's a misunderstanding on how to use these, so it actually is. But sometimes you have a residual from a previous one, and then you have a new subsequent one. And so it's actually accurate to have both of those codes at the same time. And so there's no edit or, something blocking that from happening because there are some situations where that's true. So just being careful to understand that if you only have the one and it's, not acutely happening right now and it's, we're later and we're talking about sequelas of it, then just the I-69 code is needed. If you don't also need the acute code to say that that happened, that would be inaccurate if you're talking about just one CVA, for example. And then if they've had it and it's not the acute and there are no residuals, there will be a history of code. It's a Z code, and I'll show you that in a second. Okay, so here is just an example on the top left of just an unspecified, but it's acute. It's in the 160 to 167 range. You can see it's I-6. Oh, I said one, sorry, I-60 through I-67 range. You can see it's I-63.9. So that's saying this is an acute thing happening right now. And again, I wouldn't see this in a clinic unless the next sentence was called an ambulance or something, right? So this is one of those, medical emergency, like this is not something that I would expect to see in that type of place of service. Again, if you're seeing them later after they've already been in the hospital for this, if there are no residual deficits, you'll use the Z86.73 personal history of code, and that's great. That tells the story. If there is a residual, then we need to figure out what that sequela is. And so as you can see, there's many different things from aphasia to facial droop to hemiplasia, monoplasia that I spoke of, and all kinds of different, things in between. So there are a lot of codes to capture details. And if there's something else outside of this, there is a code for specify, but not a code for it yet. And then you would, of course, capture what that other thing is to help, tell the whole story and grab those details too. There is an unspecified code, but that really should be avoided. And I can't even think of a time that would be appropriate, but it does exist. But this one code, the I-69 point, whatever it is, that's going to say they have this thing and it's because of they previously had this cerebrovascular disease issue. So it's capturing the whole story and both of those components at once in this one code. So when you're making your diagnostic statement, we want to avoid things whenever possible. Like I'm going to use CVA going forward just because it's a space saver and kind of a catch-all. But if you actually have something specific, it'd be great to have more details than just a very generic CVA, for example, if you happen to have that information available. And then after you give, the detailed of what it is, any kind of relationship. If something is due to or following or because of, a CVA, I need you to state that in your documentation. The book doesn't allow me to combine those for you. It may seem pretty obvious because that's the whole thing you're talking about is how they just got out of the hospital for a CVA and they have hemiplegia and you're addressing that. I can't assume that that's because of that. You have to make that relationship for me. You have to tell me that the hemiplegia was due to or following the CVA. And then I can use that combo code that explains that whole situation, explains that that CVA was not fully recovered from. It really gives the clinical picture on the patient. Of course, when we copy and paste physical exams, it's going to cause problems. If you say that they have normal strength or something like that, and then you're telling me they have hemiplegia, it's a conflict, and now I can't capture that. And if I was in a position where I would query you, and I'm sure you love getting those. So just a reminder to be careful with the copy and paste of physical exams. They can be troublesome. And here's just an example of a specific way with this condition that they can be. And just a heads up, the residual, the thing that you're saying they have, it also needs support, something to show that it hasn't resolved and that we're just reusing a code or carrying it forward. So the having that having let's say it's facial droop. You're observing that and you can see that, and you put a note in the physical exam that you can see that, on the right or left side, whatever it happens to be. Something showing that it wasn't an accident grabbing that code, because human error, we can click next to the thing we meant to click, right? Just something that's showing that it's hasn't resolved, and it's with your own free text that it's in there. And then other ways to show support besides just saying observed the facial weakness, if you will, in the physical exam, could be things like MRI results, and discussing those, and your overreading your take of those. Um, Having anything that you're treating them with, of course, that's always an easy one. Anything that you are observing, and if there are no residuals, then just stating that and having that code be supported in that way. And then the coder isn't having to wonder if maybe it was just left out and then querying you. They can just know that there weren't any because that was stated, and they can confidently use that history of with no residual code. So here's an example of unspecified documentation where it just says there's a cerebral infarction. Well, this is not something that they are, again, this is not in a hospital where they're taking care of that. There is something in the physical exam here that says right side weakness, but it doesn't tell me that it was due to the CVA or to the cerebral infarction or anything like that. So I can't combine it. I don't have that relationship stated. So I can just do weakness by itself, and I can do cerebral infarction. I know this is not an acute situation, so I would use the history of instead, because the acute part is not supported because of, reading this. And it returns to recheck of their stroke, so it's obviously not something that's, happening immediately right now. So this is how this would result. But if I had the relationship that it was due to, then I could put it together in that combination code. And then wonderful detail, this happens to be intercerebral hemorrhage. And then I can give even better detail that way as well. And of course, I'm told that it's their non-dominant side. And so I know that they're left-handed. I can get that accuracy in there, and all those fun things. And then here it's also giving me that you wanting them to be on physical and occupational therapy and things like that. Oh, and again, the weakness itself is specified both in the exam and again down in the assessment and plan area. So on the left, we have things like history of and weakness not linked, and how that looks. And then we have a little bit of kind of a different thought process than I've shown in examples past. And that's where this middle one is actually more than the one on the far right, because I wanted to show something. When you don't have the relationship stated and you have the acute code and the hemiplegia code separately inaccurately, you're actually causing quite the audit risk here, because it's giving a incorrect picture of the patient's acuity, and it's also having an incorrect impact on the score. And so we actually want what's on the far right, which is to combine them in that relationship appropriately and have the more appropriate score and reaction that way. And then if you're curious on, old model to new model changes, this particular category didn't really see much change besides just the HCC number itself is a different name. Okay, any questions before we move on to dementia?
Danielle, this is Dr. Fitz. Not that I have any questions, I just wanted to add a few comments on what you just explained. By the way, you did a very good job explaining this. Um, from my experience, oftentimes when a patient has an history of stroke, whether it's cerebral infarction or intracranial hemorrhage, I find out that providers keep on coding the stroke every year, multiple times during the year. So I just wanted to make it clear to, everybody on the call. So every time that you code a stroke, especially in the outpatient setting, you give the impression that the stroke happened right here in the office. When a patient presents with signs and symptoms of stroke, of course, they're rushed to the hospital. That's where they're being managed in the inpatient setting. Now, when the patient is discharged from the hospital to rehab, if there are any residuals, and the patient comes to see you in a follow-up visit, what you really need to look for are late effects of that CVA. Whether the patient has any monoplegia, hemiplegia, paraplegia, quadriplegia, and others. So I just stated the first four because these are the ones really that have a risk score in the HCCV-28 model, like other late effects like facial droop, slurred speech. So these don't have any weight. Of course, we're not only documenting to capture the risk score, we are documenting whatever the patient has. So I just wanted to make that clear. Um, Oftentimes also, I see providers capturing the late effects. For example, a patient has right-sided hemiplegia following a cerebral infarction. So they code the hemiplegia along with the cerebral infarction. So just wanted to make that clear. If the patient has any residuals, you don't need to continue to capture the cerebral infarction as an acute condition, rather, capture the hemiplegia. That's all I had to add. Thanks, Danielle.
Yeah, thank you. I appreciate it. Okay. And if there are any questions, always feel free, please, to come off of mute or throw it in the chat. I am watching the chat as I go in case there are any thrown in there, if that's your comfort zone. And just always happy to, go back if it took a while to get off mute. I totally understand. We all, go through these Zoom meetings all day, every day, right? So please don't be shy. But okay, we'll hop into dementia. So dementia, just a refresher, is a progressive decline in cognitive function affecting memory, reasoning, communication, and daily activities due to brain damage or disease. It can result from conditions such as Alzheimer's disease, vascular dementia, or Lewy body dementia, and can worsen over time and impact the independence and quality of life. There can also be multiple, things contributing to it as well, and we do have codes for that. So just wanted to give you a heads up that the dementia category is constrained, which means they have the same coefficients between the different HCCs there's one for severe, there's one for your moderate dementias, and then there's an HCC for your mild and your unspecified. And even though they have the same impact on the score, we know that that's a very different diagnosis. And so for patient care and, continuity of care and things like that, we definitely want to make sure that we're being accurate for accuracy's sake. And there's a lot of other reasons to make sure that our codes are correct. Plus, this is how we advocate for the patient. This is how CMS can easily track that they are different and having a different resource need. And then in future model updates, they can change those to reflect that. So for many reasons already, and then for future reasons, please still, even though they're constrained, of course, if available and able to diagnose it, please do, so that we can get that the correct data, the correct codes to represent them, as always with every condition. But okay, so there is a guideline I wanted to bring up about this, and it just talks about how the dementia codes are assigned based on the etiology and the severity, and then whether or not there are behaviors. We'll talk about that in a little bit of detail in a second, but just wanted to get that information to you. And then I have the impression that all of you work in clinics, but if any of you do work in the hospital, heads up, if they are admitted with one severity of dementia, and while admitted, it progresses to a more severe while there, then just the one code for the highest severity level will be reported during that inpatient stay. So we're going to need to know what caused it. Is it vascular dementia, or is it dementia and other disease? And that'll be your Alzheimer's or Parkinson's or things like that. So that's going to change the code selection. If you don't know it, it's okay to say that, and then we'll use the unspecified dementia code. It is what it is at that point. But that's the purpose of having an unspecified code, is for when we don't know it, versus, it's the fastest one to find or easy to remember, or, because I know you guys have so much on your strain on your time that it can always go and, dig into the record and find it and that sort of thing. But whenever possible, to have that level of specificity, that is something that will change the code, and is important, like, of course, to know and track about the patient, especially the severity. So mild, moderate, and severe. The coder and auditor need you to use those words. We can't just read about all the heartbreaking things and behaviors that the patient is displaying and is being described about them from their caretaker and go, yep, that sounds like pretty severe dementia to me. I need you to say that and make that decision. So just a heads up, it might seem obvious in your documentation because of all those kind of details, but it flat out said by the provider is required still. And then behaviors. So either without any behaviors yet, or they do. And then here is an example of the ones that we have codes for. And your mood disturbances would include depression. That's a very common one. Agitation and anxiety, I feel like the other ones I see also, in addition to that. And there's also the psychotic disturbances. That's your visual and audio hallucinations, things like that. So a lot of these can be, captured and represent how the patient's really doing. So etiology, severity, behaviors. So those, 3 things when you're talking about dementia in a patient, and then you'll be set. So if you are able to make a confirmed diagnosis, great. If not, then it is what it is right then. But if you are trying to make a confirmed diagnosis using vague terms like likely due to, is not going to show that you're confident in making a diagnosis, so it won't result in that diagnosis code. So just using it when you mean to, just a little reminder there, that goes for every condition really. But when you are trying to say that it's dementia due to something, please specify exactly what that something is, what that other condition was, the disease it occurs in, and copy and paste a physical exam. Again, can get you in trouble. And we need to just make sure that we go back and update it with anything that you're observing about them. And if you have scores for different things, then fantastic, include those, keep that going. And the next provider is going to want to be able to see those, and you guys can take great care of the patient and track those things. As a coder, I can't see the score being really high and decide that they're severe dementia or dementia at all. Again, I can't interpret any kind of results or anything like that. That's something that I happily leave to you guys to decide. But just knowing that that you tested them and you saw score results, that tells me that it's supported and it's appropriate to capture the dementia. Just please remember to put, in addition to the result, your interpretation of the result and what that means to you. Some other ways to support it could be talking about, again, that score, but also how things have gotten better or worse over time, any recommendations you have for them, even if it's, to see a dietitian, and medication you might be starting them on or increasing, and any other, behaviors you're observing, and any attention to the ADLs, of course, any follow-up you want them to have. Okay, so an example of some unspecified documentation could be something like chronic cognitive impairment. That's one I see a lot. And there's that likely due to, so it's great to know your differential in there, but it's not actually confirmed yet. Stable, it's something, it's not telling me if there's, that's stable for them, what their baseline versus, there's still some questioning there, but it's something. It tells me you at least addressed it, and some medication. And then I try not to, use specific brands and stuff very often. So we'll just, use your imagination and put whatever specific medication comes to mind, so that I'm not the one doing that. But this would result in mild cognitive impairment, the code for that, And that's great. If that's all we are sure about so far, then wonderful. That is what's true for the patient at this time. If, however, you meant to say dementia, then please say that word and also then give the etiology if known, give any the severity, and give any behaviors there may be. And that would, of course, I would anticipate seeing in the physical exam an update there. And then that will be a different code completely. And this one does have an impact on the model. And then just a reminder that it's best to put the medication and the dose that you expect them to be on whenever possible in your plan. I know it's just another detail, but it's one of those great ones that really help with making sure things are up to date. And then from the old model, it was just with or without complications. We didn't have codes for the different severity when the old model was made. And so now that they exist, when they went to make the new model, now that's why the new model is divided by severity instead of the behavior detail. So anyway, if you were curious what that looked like, that's how that looks now. Okay. Any questions or comments for the dementia topic?
One quick comment. So oftentimes these patients with dementia, they are on cognition enhancer, they're on Aricept. Um, Also, with these patients that have mood disorders, oftentimes there's this code that is submitted. It's the F41.2, which is mixed depression anxiety. Now, if with this unfortunately this code does not risk adjust. There is no weight when you send that code when you submit that code for depression and anxiety. Um, if these patients, for example, are on antidepressant long term, for example, they're on Zoloft or they are on Xanax for their anxiety. With that dementia code, you have an opportunity to submit two more HCCs. You can submit the HCC. We talked about that last time. You can submit the HCC for major depressive disorder, which in this case would be recurrent. These patients have been having dementia for quite some time, so that's a chronic condition. So their depression will become chronic, and you would grade that depression based on your PHQ-9 score. That will give you a mild, moderate, or severe major depression disorder. And then you have an opportunity to capture the sedative dependence. Patients on Xanax for their anxiety. So basically that patient has a potential of 3 HCCs. So I just wanted to add that.
Thank you. Yes. So if they have depression, it's going to be their dementia code is going to be with the mood disturbance. And if it's more than just depression, your depression unspecified, just your run of the mill, if you will, random. If it's actually major depressive disorder, absolutely, that's an additional code to capture that type of depression. Where this having with mood disturbance would just be with normal depression, if you will, less severe, not major. But if it is with major, then that's an additional code you would add to give that additional detail. And then, yes, you're right. It is just like we talked about before, it is an HCC itself as well. And then so you can see how it kind of, as you keep giving more details and keep telling the story, it keeps progressing that way. So I think it's a great call out.
Of course.
Okay. Just make sure that I didn't skip to the wrong one. Okay, fantastic. So severe persistent asthma. So we know there are multiple types of asthma, and to fit in the topics we wanted to today, I'm just going to focus on the one that happens to be in the model, and it kind of applies across, but just to kind of explain that. So severe persistent asthma is a chronic respiratory condition characterized by frequent symptoms, limited airflow, and daily reliance on high-dose inhaled corticosteroids or additional medications to control inflammation. Patients often experience nighttime awakenings, reduced lung function, and an increased risk of exacerbations despite ongoing treatment. So severe persistent asthma codes do belong to an HCC. It's HCC 279. Okay. But we know with asthma that there are different types. So when you are coding, but when you're, talking about the diagnosis of asthma, be very specific, ideally, with what type it is. So whether it's intermittent or it's persistent, and if so, is it mild, moderate, or severe? The status, is it uncomplicated or is it with an acute exacerbation? Is it decompensated? That's another word that'll get coded that way. Or is it with status asthmaticus? Okay. So avoiding just saying asthma unspecified. If you know the more specificity, documenting it, supporting that specificity. For example, if you say it's decompensated or with an acute exacerbation, I should see that in your physical exam versus a copy and paste of normal lung sounds, no crackles and wails, right? I should see something in the HPI ideally, kind of explaining a little more, and then either even if the plan of treatment stays the same, stating that, or possibly, an increase, or maybe why you're not doing an increase right now despite it. Whatever happens to be the case in your, obviously in your clinical decision making, but just kind of seeing that, again, it wasn't an accidental clicking of, the wrong code next to the one you meant, just having every piece of it be supported really helps. And so again, you want to make sure you have the type and the status when you are looking at a diagnosis of asthma. So some of the things that can support it, maybe they had a spirometry test done and you're showing the results of that. Maybe they are on, you're telling which corticosteroid they're on and how often you have them using it. Maybe there's, they need to follow up with a pulmonologist. You want them to go see a specialist because of how it's progressing, whatever it may be. Just kind of giving the heads up and what's going on really helps show that it is, again, supported and something that is on your mind, even if it's, so ideally, if it's something that you are addressing, then of course it's a part of your E&M level and things like that. But if it's something that has an impact on a condition you are addressing, it's still, again, appropriate, and the coding rules to capture that coexisting condition that could have an impact on the care you're giving for something else. And I feel like our lung conditions are definitely ones that more often than not fall under that. So just a reminder there. Here's an example of some unspecified documentation. So it says asthma exacerbated. It says to increase the inhaler use. So that's actually great. But good, better, best. It'd be even more ideal to know what type of asthma we're talking about versus just asthma. So if this is what I have, then this is what is supported, what code is supported, and how that goes into play. Take note that in the subjective section it says patient with a history of congestive heart failure presents, and that's why I didn't capture heart failure here, is because it says history of. And we know that typically clinicians mean that they walked in the door with it versus a new diagnosis, but coders and auditors are forced to treat it as resolved until proven otherwise, as a true history resolved kind of condition until it's shown that that wasn't what was meant. So I have no other support here for the congestive heart failure, so I have to leave it in the resolved world and not be able to capture it with the current state of the documentation. If, however, it didn't say history of, it just said with stable, that is active voice telling me that they have that still. And they're even giving me that that it's chronic and it's the combined systolic and diastolic type. And we love details. We have all these beautiful codes. It's just, great to get to use them. It gives me a little bit more about what's going on with the patient. And, after they're having the symptoms are worsening after they work in their garden, things like that. The physical exam is reflecting findings which is to be expected if you're saying that they're in there with an exacerbation. I would expect to find something that you're hearing when you listen to their lungs. There's also specifying that it's severe persistent asthma instead of just asthma with an exacerbation. And so now the codes are going in to show those as well. And then here's what we have is when you leave it as history of and you just say asthma, this is all that it's gonna show and be there for the patient, versus when we have, at least in the middle, we have the specificity of the type of asthma and we still use that history of verbiage, so we still can't grab that congestive heart failure. Versus if we had the active language and didn't use the history of and supported the congestive heart failure, got to grab the severe persistent asthma. These actually have a disease interaction with each other, and that's an additional factor that goes into the score because they anticipate these things needing more monitoring, having more clinical significance. And so to help compensate for that and make sure the resources are there for that, there's that extra disease interaction that's added as well. As far as the severe persistent asthma codes, there's uncomplicated, there's with exacerbation, there's with status of medicus. And those are all in the model, in case you were curious on that level of detail there. So next will be COPD, but before I move on, were there any questions on the severe persistent asthma? Okay. So going into our chronic obstructive pulmonary disease, this is an umbrella term for several lung diseases, and they prevent proper breathing. We often see this with asthma, so it kind of makes sense to go together. We also see this with emphysema a lot. Fun fact, the severe persistent asthma HCC actually trumps the COPD and emphysema HCCs. So just to kind of further show how important it is to capture if that happens to be the case for your patient. But COPD is an HCC. It shares an HCC with emphysema. We still want to capture if it is emphysema, that detail, because it's more specific. But we can absolutely, use our COPD if that's the case. And that's what we know. So here are some examples here. So there's COPD unspecified any further versus with a lower respiratory infection versus with acute bronchitis or an acute exacerbation. Again, decompensation is a word you can use that will get your coder or auditor to be able to use the exacerbation code. There's COPD with asthma. There's a newer code for that. And then COPD unspecified with emphysema would use the emphysema code. If the COPD has a specification to it, we can capture that in addition to the emphysema code if that's the situation for the patient. That was a more recent update to the code set. Before, we were required to only use the emphysema code and never the COPD code, even when it had a detail to it. So that's great, we can do that now. So if you've been told that in the past by a coder, they weren't wrong back then. It's just not current now. And let's see, so for the code selection, we want to make sure that we have the type specified, the severity as to whether or not it's exacerbated, and any kind of additional, respiratory failure or anything like that that might be going on. And then it's going to ask this code is going to ask the coder what's going on with their smoking. Are they a smoker? Do they have a history of smoking? Anything like that. So they'll start looking in your note for that. So just a heads up there. And then you probably, if they are a smoker, ask them about it. And so just kind of putting the results of that conversation in your assessment and plan with your COPD is wonderful to kind of, complete that picture and give all that information in one place. And then avoid using vague terms like shortness of breath. I've seen where they're like, oh, well, they came in for shortness of breath, so that was the diagnosis. And then in the free text, it talks about their COPD, and it's like, okay, so we have a confirmed diagnosis of COPD. We want to use that diagnosis and that code. And the shortness of breath is a sign or symptom of that diagnosis, and coding guidelines say when it's a normal symptom or sign, we don't capture it separately. So it's actually more appropriate to switch that and just capture the COPD and not capture the shortness of breath. So some examples of support for this condition specifically would be explaining what they're experiencing, and if how they're doing on any medications they're on, how often they're taking it. If there's any recommendations you have for them to see an allergist, or again, spirometry test, seeing the pulmonologist, anything like that. All of that counts, showing me that it's current and not resolved, and it's relevant, and it's something that you're monitoring, evaluating, assessing, or treating. Again, you only need one of these elements. It's ideal, of course, to have more than one, but if you only have one and you only have one, that's fine too. The diagnosis status plan. So yes, the meet elements is what your coder is using to try to find ways to show it was relevant and therefore appropriate to capture the diagnosis code. As a reminder, the DSP is for you, for help us as a helper for your documentation. So the diagnosis as specifically as possible, the status of it, and your plan for it. And that they'll find the meet elements within your diagnosis status plan setup. So here's an unspecified documentation example. And so here we have that history of going on again with our congestive heart failure, which you already know is going to be an issue. Then we have the obstructive lung disease. It's not giving me the words I need to get to the COPD code. It actually gets me to the lung disease, not otherwise specified code, the J98.4. So that's how we would end up with that kind of documentation. Our chief complaint just says to recheck conditions, so it's not helping us either. Versus if we could have some specificity in there, we would, of course, as expected, have findings in that physical exam. We can get a little more detail with our obstructive lung disease, that it's chronic obstructive lung disease and it's COPD, and that's how we're going to capture it. Talking about having an inhaler refill and, current beta blockers really supporting that congestive heart failure, not calling it a history of because it's not resolved. All those great things. And like we saw before, it's going to trigger a disease interaction between our chronic lung disorders and our congestive heart failure. And so you can see that here as well. And again, it's just if we weren't able to capture anything, but if it's true for the patient, then it's fitting and it's exactly what they're going to need, which is not much. So their demographics are going to take care of that, any wellness visit, any kind of screenings or labs. And if they don't have any, chronic things going on, then that's fitting. But chances are their heart failure is not really resolved in a history of. We were just stuck with the coding on that. So it'd be nice to be able to capture that and have that be more appropriate. And then, of course, if it really is chronic obstructive lung disease versus obstructive lung disease, then we can use that code, which will be in the model and appropriately cause that HCC, and then those together will cause the disease interaction again to be added. So it should fit, reminds me of Goldilocks, right? Not too hot, too cold, right in the middle. Like it should fit what the patient's really needing. And so again, we are adding the severe persistent asthma. That wasn't a thing before. And so it kind of moved around a little bit of the HCCs in these groups from the old to the new. Okay, so there's the QR code for the survey, and it's going to help with getting that CME credit, but happy to answer any questions or would love to have any comments about COPD or any of the conditions at all, really.
So Danielle, it's me again. For these COPD patients that have an underlying asthma, I'm glad that you were able to highlight the importance of capturing the severe persistent asthma, which is a condition that has been added this year that has a RAF score of 0.8 versus the COPD that has a RAF score of 0.319. So anytime, you have the opportunity to to evaluate a patient with severe persistent asthma, it's good to capture that code. For COPD in general, COPD, we have it's the umbrella that includes all forms of chronic bronchitis from mucopurulent or even simple chronic bronchitis. So you have this patient that is a chronic smoker for 30 years. That patient has that constant cough, that chronic cough, that lasts 2 weeks or more. Patient comes back to the office every year with, the same cough. So you can capture that simple chronic bronchitis or smoker's cough. This is also an HCC that has a risk score associated with it. Oftentimes, and I think we talked about that on one of the previous calls. Oftentimes, you have patients with known COPD, but they need supplemental oxygen. If these patients are on oxygen long term, and because of them being hypoxic or what have you, then you have to think about capturing the code for chronic respiratory failure. Chronic respiratory failure has a risk score higher than COPD. You may still capture your COPD code, but adding that chronic respiratory failure code adds up to the patient's risk score. Oftentimes I get questions, well, my patient is not on oxygen all day, so patient only needs it at night. So in other words, the patient only desaturates at night, and that's when they are on oxygen that brings their oxygen saturation level to a decent value. So my question is, are you comfortable as a provider to remove the oxygen from your patient for one night? And if the answer is no, so your patient is dependent on the oxygen because of their COPD, so therefore their chronic respiratory failure has to be captured as a consequence. Thank you.
Ooh, I love it. Such a good point. Thank you. I appreciate it.
Pleasure.
Any other questions or comments? Okay. I wanted to get through all of those conditions, so I hope that it wasn't too fast. And again, we'd love your feedback. Additionally, it is helping them track for who was here and stay to the end, all those fun things for that CME credit that I want you to get. So please, take care of the survey part, but otherwise have a great rest of your evening. I will stay on as all of you drop off in case anyone thinks of another question or wants to ask more one-on-one. But if not, then have a great night. Happy Friday Eve, and I'll see you again next week.
Thanks, Danielle. That was a great presentation.
Thank you. I really appreciate your assist with it. It always enriches it, makes it better, and I appreciate that.
Anytime.
Yes, thank you. You guys have a good night.
I have a question regarding COPD and asthma. Can you, like smoking, does it make RF factor affected? History of smoking? That wasn't included.
So the status of smoking is not having an impact on the model or the score, but it is telling the patient's story, right? And how even though they have the conditions, they're still smoking. And that's still important detail to document and capture, and can come into play in a lot of other ways as well. And it also lets the payer know, hey, that they need to, give them education on, stopping smoking and things like that, in addition to support your efforts. I'm sure you're counseling them to stay away from it as well.
Okay, thank you.
Yeah. I always find it interesting when I read that a patient's still a smoker even when they're on oxygen tank and things like that. It gives me a little panic attack. And it just, humans are very funny like that.
Yeah, that happens very often, surprisingly.
Surprisingly, yes. Okay, I'm gonna give it another minute before I just assume everyone else walked away from their computer. Okay. Feel free to reach out if you have any questions. If not, I will see you guys next week. Have a great evening.
All right, thank you.
Thank you.